Thanks for coming. I'm Lane Cooper, one of the anesthesiologists. I want to go over regional anesthesia and what you all see in the PACU and how it may affect what you expect and what you do. So we can go ahead. Go to the next slide, please.
Where is my? Oh, here. Sorry.
No worries. So first, there we go. So the first thing you want to go over is the actual local anesthetic, because that can have an effect on how long the blocks last. So I think by now everyone is experienced with Exparel. It's a liposomal bupivacaine. It's basically local anesthetic with a little fat globule around it that allows it to have an extended release effect over 2 to 3 days. So it's great. It's allowed us to use fewer catheters. So less work, less maintenance. You don't have to call to hook those pumps up. That Exparel is great, and we do it with more and more blocks now as we've gotten more experience with it. Ropivacaine is a longer-acting local anesthetic. Typically, we expect it to last about 18 hours or so, more than enough time to get them out of PACU. Lidocaine is shorter-acting, usually a couple hours. We don't do many blocks with just lidocaine, just because if we're going to do it, we want to get a more prolonged effect. But what we do see, especially for Dr. Jafarnia, his carpal tunnels, a few other smaller cases, we'll mix ropivacaine with lidocaine as a little cocktail with the expectation that it'll wear off before the patient goes to bed at night. That's some of the feedback that we got is if we give them the full 18 hours, they go to bed with their arm in a sling and they still can't feel it and they wake up in the middle of the night. So this mixture allows us to get them comfortable, get them home, eat dinner, and then have it start to wear off so they can get comfortable before they go to bed. Final thing is additional medications. Sometimes you'll see ropivacaine with dexamethasone. That helps to kind of have an extended release effect, gets us from 18 hours, 18 to 24 hours, sometimes longer. We really don't do much else here. Other places may use clonidine, Precedex, Epi, with the expectation that it'll help extend the lengths of those blocks. But again, at this facility, really don't do much more than Decadron. Next slide, please. So one of the most common blocks that we do is a supraclavicular block. Do it for hand, carpal tunnels, radius ulna, cubital tunnel. It's kind of a catch-all for the arm. Of course, because it's a brachial plexus block, it affects sensory and motor, so that arm's going to be nice and floppy when they come out. For most of the surgeries we do it on, really should catch just about everything. Every now and then we'll do, I know I will, maybe some of my colleagues will do an intercostal brachial supplement for cubital tunnels. Intercostal brachial nerve covers this area down here, just a little extra local subcutaneously to help catch that area as well. Really not a whole lot of consideration since we use ultrasound. Historically, one of the risks was the pneumothorax, but we really shouldn't be getting anywhere close to the lung since we're doing it ultrasound guided now. Great block, very common, should cover just about all that you need. Okay. Next one, interscaling block. So this one we catch a little bit higher up on the brachial plexus. Good for shoulder surgeries, distal clavicles. Kind of an interesting block because you'll also see them be able to use their hands. Sensory may be a little off, but if they're wiggling their fingers, don't be alarmed. That's it's not a bad thing. One of the big issues with this, though, and this is something the anesthesiologist should assess, but we don't always, see it talking to the patient, see it in Epic. If they have any sort of pulmonary compromise, because the location of the phrenic nerve traveling alongside the brachial plexus, if we put local anesthetic in that area, we're also going to bag the phrenic, which means that the hemidiaphragm on that same side is not going to work. Right? When you breathe, you have multiple muscles, intercostal muscles, diaphragm, all working together to expand your chest wall and expand your lungs. That diaphragm goes, well, it's going to be a little harder to breathe. So folks with diaphragm issues on the contralateral side, it's actually, this is contraindicated, but you do get some folks with pulmonary compromise, COPD, restrictive lung disease, where it may show up in PACU if they're having difficulty breathing. So that's one thing to keep in mind. Another thing with this, depending upon the surgery, If it's a clavicle, sometimes it doesn't cover the more medial aspects. It may get a little pain here. Also for shoulders, if they're doing a lot of pulling and tugging with the muscles, you may still get some soreness in the axilla, pectoralis in the back. So, that shoulder, between the innervation and everything involved with some of these bigger surgeries, they may still have some discomfort. So don't be alarmed with that. Usually some of the Baxit helps out, especially if it's a muscle spasm type of pain. But this is one that we typically use Exparel for these shoulders now, so hopefully get a good 2 to 3 days of good relief with those. Okay, next one please. Going down to the leg, the femoral nerve block. We don't do these quite as much as we used to, but this catches the quadricep muscles, as you can see in the front here. It also affects motor, so that's why we've kind of gotten away from it. It is still good for quadricep repairs, patella repairs, AKAs, things where they're really not going to be extending their knee. One of the issues, we used to do these for total knees, but then the knee would buckle and they wouldn't have the strength to be able to get up and move around on it. So that's why it's a more limited block now. Great for pain control, just with the other goals that we have after surgery, not quite as common. Next one, please. So the adductor canal blocks, this is what we move toward. So, it basically covers sensory-wise on the knee, the same place that the femoral would, but it does not compromise motor strength. So the benefit of doing this is we still get, pain relief, maybe not as significant as we did with the femoral, but they're able to get up, move that knee around. So very, very common. Same thing with ACLs. Some of the surgeons for more involved meniscus repairs will request that. Depending upon the surgeon, we may use Exparel, or for a lot of the joints now, we've been using ropivacaine because they're putting Zen Relief or their cocktail in the capsule. We don't want to double up on too much local. But yeah, this is fairly new within the last, 5-7 years. We've done a lot more of these. Next slide, please. Next is the popliteal block. Also not quite as common. It does cover motor and sensory. So if we block the popliteal, which is just basically a sciatic nerve block lower down just above the knee, that foot's not going anywhere, right? So use it for ankle, tibia, foot surgeries. Dr. Hansen, of course, does not do many blocks, but his area would be the one where we would most commonly do these types of blocks, that foot and ankle surgeon. Many times we will also do a saphenous or an adductor canal supplement because there's a little strip along the medial aspect of the lower leg down the ankle that's not covered by these nerves. So if we do that supplement, that's just to catch that medial aspect as well. Great block, works well, we just don't do that many of them here. Okay, next slide please. This is another newer block, the PING block. Do it for anterior hips. Basically there's a bunch of nerves that kind of come around the capsule here where it's going to be working, and just dump some local anesthetic in that area. It is not a block intended to be totally numb. It's more of a supplement to help reduce the amount of pain medicine that folks have to take to stay comfortable. But it does work well. Some facilities use it for hip fractures. They're actually able to put that block in, let it set up, and they can sit up with a fractured hip to get a spinal. But it's usually just anterior hips at this point. Sometimes for fractures, we'll do it as well. All right. Now to the truncal blocks. So we see a lot more of these now as well. So the QL blocks, we do these in the OR after the patients are asleep. Typically we do use Exparel, so hopefully it'll get them a good couple days of relief. Laparotomies, bariatric surgeries. The goal is similar to the PING block. It's not going to make it totally numb. We want them to be able to reduce the amount of pain medicine they have to take to stay comfortable, and hopefully reduce those side effects, especially constipation for some of these GI cases. It should cover a good part of the trunk here. Difference between this and a tap block, we go a little further back. Tap is more of a superficial relief, so good for incisional pain. QL should get more visceral pain coverage as well, okay? Again, not totally numb, but we have seen some pretty profound improvement with some of these folks. Had one patient come back and tell me he kept reaching to pull his pants up because he was still numb, he couldn't feel where his pants were. So they do work. Then go on to the next one, please. So these are the other truncal blocks. So I kind of put all these together. So the tap block, good for inguinal hernias, again, more superficial incisional pain. The rectus sheath block, which we do for one of our bariatric surgeons. So we do covers both sides here. And then the subcostal tap, which we do underneath the rib line here. So it helps catch all this area here. And of course, QL is everything. So this is a good little diagram. Again, QL we've moved almost completely toward, but for these other ones, just in case someone comes with you and they had a subcostal tap and a rectus, that's why. Still covering a good amount, but mostly just that incisional pain.
Could you ever combine a tap with the QL or anything, or is that too much?
A tap and a QL would be kind of redundant.
Okay.
So, especially with the QL, I mean, it catches everything, it's more visceral, so I think that's what we go toward as well, because it's, one injection on each side, you should be good. Okay. Did not cover spinals and epidurals. Of course, we really don't do many epidurals anymore, just because we have Exparel and we can do, the QL blocks. The spinals we do for our total joints, hips, knees, hysterectomies. I think everyone's pretty familiar with them. Of course, benefit of that is it's very numb. So we can reduce the amount of pain medicine we have to give, reduce the amount of anesthesia, can reduce side effects, wake up more quickly. Of course, there's always a risk for urinary retention with the spinals. For hysterectomies, we'll many times put morphine in with the spinal. Usually lasts about 18 to 24 hours. Goal is a nice baseline level of pain relief. Of course, you can get some itchiness and nausea with that. But we've largely moved away from that, from giving the Duramorph for the total joints, because we want to send them home the same day. If they get Duramorph, we have to keep them under monitoring for 24 hours. So I know some folks will ask, why do you put morphine, something longer acting? Well, it's kind of just a conflict of goals, but we found they do pretty well with that straight spinal with the local anesthetic along with one of these blocks. All right.
Can you talk about the contraindications to why we don't give certain patients spinals?
Sure. So, number one contraindication for any block is patient refusal. So if they don't want it, we're not going to sell them on it. We're not going to push it. Another thing for spinals is if they have extensive hardware in their back. Some folks have a couple levels fused, and we can go above or below that. But if they have multiple levels, Harrington rods, or just sometimes depending on how extensive any sort of fusion is, we don't want to introduce any source of potential infection for that hardware. Another one would be blood thinners. So the risk of hematoma is real. It is rare, but that's why you'll see patients on Plavix, Coumadin, things like that. We have guidelines for how many days they need to be off of those before we can safely do neuraxial anesthesia. Because a hematoma is catastrophic. Unless they have emergent surgery, they could have lifelong neurologic compromise. For our hips, we typically don't do spinals if it's fracture. Part of that is just the positioning. Someone has a fracture, sometimes it can be very difficult to position them. But for all of our elective totals, hemis, all that sort of stuff, we'll go ahead and do it.
What about the emergency risk that we should look for here for intravascular local anesthetic?
Sure. So local anesthetic, toxicity, usually we use more ropivacaine than bupivacaine. So if you have any sort of seizure activity, involuntary movements, that'd be more common with ropivacaine. Of course, Exparel has bupivacaine, which you could see arrhythmias, cardiac irregularities. If someone is very slow to wake up, that's something you may need to keep in the back of your mind. Everyone presents differently, so if you have any concerns and you know that they had a block and you know they had local, don't be afraid to give the anesthesiologist, give the board runner a call, because it is something that we can fix, right? If you suspect that, we can get intralipid, get that hanging, and it's kind of magical. If that's the cause, it fixes it pretty quickly.
So how many injections do you have to do with the abdominal blocks? Like for the supraclavicular and the interscalene and the popliteal, it's usually just like one injection, right? And so for that one, since it covers the whole, like, for example, the, what's that, the QL block, how many injections do you have to do, just out of curiosity?
Sure, just one on each side.
Oh, okay.
So one on each side, same, so with the rectus sheath, one on each side, for the subcostal tap, one on each side. Theoretically, you could do it unilaterally if you wanted to, but with the surgeries that we do here, typically we'd rather just cover it all. So we'll do bilateral.
Oh, okay.
Dr. Cooper.
Michelle,
Yes.
hold on, Michelle. Let me turn you up.
Okay. Dr. Cooper, I was just wondering, are we not using rec now, like for abdominal, like appies, lactoses? I just noticed more of the Exparel being used.
So typically if rec is used, that's something the surgeon will inject. Shoulder, knee, put in the capsule. So certainly rec is being used, but that's something we communicate with the surgical team, again, so we don't overdo it with the Exparel. So that if you hear rec's being used, that'd be the surgeon injecting that